Good afternoon, everyone. I'm glad that you are here, and I would like to present about the amniotic membrane still from a little bit different point of view. What I would like to talk about is how we assess the benefits of the amniotic membrane use, the therapeutic use, using some ocular imaging techniques. So the purpose was to see not only clinically and practically looking at the slit lamp of the benefit, but also to have an objective way in order to monitor the benefit of the treatment. And this was using anterior segment OCT. As you know and you heard before, amniotic membrane is the innermost placental layer, which has a thick basement membrane, and it's an avascular stromal structure. The benefit is due to the presence of cytokines and growth factors. The transplantation with the amniotic membrane is important because it does protect and insulate some sites from the host environment. Because of this, it does have a triple property. One is the anti-inflammatory one, anti-fibrotic as well, and anti-angiogenic. You can use it either as a temporary graft for a period of time that it's limited, or as a permanent graft. Also, you can cut it and put multiple layers, doing a sandwich, and put a larger portion surface on the top of it. You can also use no sutures by using the T-cell glue, the fibrin glue, and there are some other options to use a polycarbonate ring. What are the indications? The list is increasing by the time as it goes by, but we know that it has been used successful so far in superficial corneal erosions and persistent epithelial defects. In neurotrophic corneal epithelial defects, patients that are especially immunosuppressed. New indication is going to be patients with diabetes, which is very often, and we heard recently about dry eyes incidence in patients with diabetes, so a new indication. Also, it has been used successfully in patients with corneal ulcers that are progressing in time, and there is impending perforation. When there is recalcitrant corneal inflammation, where the medication are not using or are not enough, an amniotic membrane gives a significant improvement. One very significant and an indication which amniotic membrane brings a lot of benefit is chemical and thermal burns. And why is that? Because it promotes the epithelialization, it does decrease the ocular inflammation, and also very important for the patient, it does decrease the pain and discomfort they experience. There are quite a bit of patients with acute Stevens-Johnson syndrome that we can use it. Also, they do develop symblepharon, as you know, and by putting a large size amniotic membrane, it's very useful in order, sometimes, if you are quick enough, to prevent symblepharon formation. When it's already formed, you can dissect it, and then by putting a membrane and a scleral shell, you can preserve that fornix, and the amniotic membrane is preventing from recurrences. It has been used with success in stem cell transplant or corneal transplant. Also, you heard Dr. Wu earlier about all kinds of conjunctival tumors in which it has been successful use. Why is that? The reason is the inflammatory properties that it's bringing by its structure. And we know already that the hallmark of the ocular surface disease is inflammation. It can be either in the cornea, the conjunctiva, or the eyelid. And the amniotic membrane, it's addressing both the corneal inflammation and as well as the conjunctival inflammation. What happens if we don't, and if there is uncontrolled inflammation? Then the patient is in big discomfort, there is chronic pain and irritation, the healing is delayed, sometimes there is additional tissue damage that can occur, and also there are complications and vision-threatening complications like scars that are becoming permanent. So our goal as surgeons is to decrease that inflammation, and the way to do it, one way is through the amniotic membrane, because it does allow a better wound healing. I would like to go over a few examples. And this is a patient that came with keratitis, and it has significant corneal thinning. And we placed amniotic membrane, and then we wanted to see, did it work or not? Sometimes looking at the cornea, the slit lamp, and especially in an inflamed eye, it's very hard to visualize the thickness. By using an ocular imaging technique like anterior segment OCT, we can actually measure from the epithelium to the endothelium. So these are the pictures before and after. This is a patient that had Sjögren disease and significant dry eyes. Also, she did have scleroderma, and she started to have corneal thinning. The other patient was a patient with keratitis. So you can see before and after, by measuring with Visante, we can see that there was a thickening of the tissue after placement of the amniotic membrane. And this was the objective proof of the goal that we are talking about. So it's not only a subjective for the clinic or what we see at the slit lamp, but actually an objective benefit that it does restore indeed the corneal thickness, and it does promote the epithelial healing. So we can prove that. I wanted to bring a study that we did at the University of Arizona, and this was many years ago. Actually, this was before the AmnioDisc was available, and at that time I did use the Procera. So it does have the amniotic membrane, and that's the purpose that I wanted to bring, that the tissue brings so many benefits for the ocular surface. So it was a retrospective review. It was a small case series, and as you can see over here, the pathology was different. There was a corneal epithelial dystrophy, a pseudophakic bullous keratopathy, some patient that had significant thinning secondary to infection keratitis, a patient with Sjögren and with very bad ocular surface that also developed thinning, and a non-healing epithelial defect. And we looked only, not only at the objective measures to see how the cornea did, but we did look also at the ocular pain. And at the time, we did have patients filling out a questionnaire regarding the discomfort and the pain before we placed the amniotic membrane and also afterwards. And the results showed significant improvement in the corneal thickness after the amniotic membrane was placed, but also significant improvement of the discomfort. So they were much more comfortable afterwards. This was another patient that was visualized with the Visante. As you can see, there was not much to tell when we're looking at the slit lamp. It was a pseudomonas keratitis with a lot of corneal thickening, some areas of thinning, completely opacified cornea. And you can see at that time how much thinner the cornea involved was. Also, it's a good way to monitor and to decide if you need to take the patient to the operating room and not to have a surprise Friday afternoon. They are coming up with a perforation and you need to take them to the OR and you don't have the tissue available. And you can see later that this tissue was much better. A few other cases that I would like to bring, also with very bad ocular surface, and this happened in a patient that has Sjögren and scleroderma that had bilaterally involvement. You can tell that the cornea centrally was very thin. This affected her vision tremendously. I remember that she was coming to the clinic with a hat with large surrounding and covering with a scarf as well. So we had to take everything out, and I was holding the lids to take a peek. And you can see over here that there was about 200 microns left of the thickness of the cornea in that case. Another case where the ocular surface was significantly affected was this patient that had previously underwent a corneal graft. And the question is the cornea hazy because the surface is very bad, or because it had a tube placement prior? Was it endothelial failure because of the touch of the graft? So again, we are looking at these two different cases. As you can see over here, the hazy cornea was due to the fact that there was touch between the tube and the endothelium. But over here, this was not a problem, and it was diffuse haziness, irregular surface, very bad tear film, and we wanted to do something in order to improve that ocular surface. The tube was well visualized in all meridians, and there was no corneal touch, so we eliminated this possible etiology. Another indication would be in patients that are using chronically glaucoma drops, and we know that sometimes it's 2, 3, or even more drops. And because of the preservative and other issues, the surface of the cornea is not happy. So this is another possibility to use the amniotic membrane to try to comfort the patients. The choices that we have available, you heard about them before. I would like to point different characteristics that are key in its use in clinic and in the surgical room. So we do have the Amnio 2, that it's thin. It's 35 to 40 microns. There is a single layer of native American amniotic membrane, and it does retain the more native characteristic of the biostructure of the amniotic membrane. For cases in which we do need reinforcement of the tissue and we need it to use it mostly like a patch, we do have available the other one, the Amnio 5, that it's about 3 times thicker, and there is a multi-layer that includes the amniotic membrane and the chorion. And this is key, and I would like to emphasize this because in this way it provides the most anti-inflammatory properties by having both together in one. And also the thickness, it's due to the fact that it does retain collagen from the placenta. IOP came with the amniotic disc that I found it very, very useful. And the big plus in using in the clinic is that, first of all, it's not only in the OR, but it's easy to use in the clinic setting. So you don't need much. You can use it at the slit lamp or just grossly placing it. Usually I do push the chair down for the patient to be horizontal and to be comfortable. I place a drop of tetracaine, placing a lid speculum, and then you take and keep the sterile condition, place the amnio disc on. I find it very useful to smoothen up, and because it's practically like a paper-thin layer, to put it on the cornea, localize very well, push the margins down, and then hydrate it, and put, very careful, 1 or 2 drops of BSS, which is sterile, of course, not more. If you put too much initially, it can move a little bit, and then it's very hard. And we saw some videos earlier on that we need to kind of smoothen up those folds and wrinkles of the membrane under the corneal lens, under the contact lens, and sometimes it's a little bit more difficult and time-consuming. So just a little bit of BSS, I find it much easier, and then to place a lens. The contour lens comes in the large size diameter, and usually it's about 18 millimeters. So it does cover all the amniotic membrane that you place, and also it covers beyond the limbus. The only downside sometimes is the patient, especially with the small interpalpebral fissure, and Asian patients do feel it a little bit more. So I was talking earlier to the colleagues here, and a soft contact lens with a smaller diameter, it's also acceptable. You use the amnio disc and you can put something smoother and better tolerated by the patient. So looking at the properties of the amniotic membrane, I mentioned about the presence of cytokine and chemokine. There is, in the thick one, the collagen is preserved, and there are various types of collagen, 1, 4, 5, and 7, that are present. Also the elastin, fibronectin, and laminin. To get it in late term and to talk to the patient, usually I tell them that this amniotic membrane is nourishing your ocular surface. It's feeding, it's like food. You can imagine that if you don't have anything, it's going to be bad and you are hungry and all that. So I think it's a very easy way for them to understand exactly what it is, especially patients that do not know what the growth factor of cytokine is. And then they understand the process. Also, I would like to emphasize the fact that it does have interleukins, especially 4 and 10, which are responsible for inflammation. So it's acts against them. Also, we know that the metalloproteinase matrix involve in inflammation. So the inhibitors of that are very important to be used in order to cut down on the inflammatory process. What about the growth factors? There are 13 growth factors present, and you can see all of them present over here. What is important is to know that all 13 are present in the fresh amniotic membrane, but again, all of them, all 13, are present in the processed amniotic membrane. So you do not lose anything, and all those rich foods that I was talking about, it's still present there. Among them, the very well-known one, the fibroblast growth factor, epidermal growth factors, and right, we do put it on the epithelium, and also the PDGF, the platelet-derived growth factor. I would like now to present a case that did very well actually with the amniotic membrane, and I am so glad, especially because the patient is so happy, and we use a few products from the IOP that made it a success. The patient was an older lady, 19 years old, whose history is that she was complaining of a large growth that she noticed in the right eye. And actually, 6 months previously, she was seen elsewhere, and she was diagnosed with scleritis, but because of the age and other issues, she did not really follow up. Over time, she had more symptoms and progression, and she noticed that that growth was increasing in size. Also, what brought her to the clinic actually was the fact that the vision was decreasing, and it was slowly getting very bad. Important in her history was that she did have a long history of rheumatoid arthritis, but it was well controlled. She didn't really have significant joint pain more than other people that we see with dry eyes. So she was seen actually by one other colleague, and she was recommended and scheduled to have an enucleation or evisceration, and I will tell you why. And she was concerned, but she was at peace with the idea. Nevertheless, she came for a second opinion. And this is my patient, actually, that was around 20 years of age. The vision was very important to her, and actually at the time she was making drawing and she was doing a map for the army. So I found it very interesting. Actually, she gave me this after she had the surgery, and she was very happy. When we look at her, the slit lamp, the vision indeed was decreased. It was to 2400 in that eye. She did have some restrictive movement on the extraocular movements and the restricted visual field. To notice that the pressure was 3 millimeters of mercury in that eye. And when we look at the slit lamp, I hope that it's a little bit visible. It's not the best photo. There were descendant folds. The chamber, the interior chamber, was pretty shallow. So there was some leakage, but when we did the typical Seidel, I didn't see any leakage. Away from the cornea, she did have this very thick, yellowish, hard mass, and this was the portion, the occurrence that brought her to the clinic together with the pain. Every time when she was blinking, she was having tremendous pain. In the other eye, when we looked at, there was a senile plaque. And as we know, we see that quite often in patients that are a little bit older. Thinking about scleritis, and we know that it can be anterior or posterior, either localized or diffuse, or just like a nodule. In this particular case, our patient presented with scleromalacia perforans, and we thought that this was related to history of rheumatoid arthritis. The calcific plaque that she had, sometimes we do see calcific plaques and plaques in older patients, but they are very limited in the way that they produce symptoms or in terms of the surface. And very rarely they came out and they are extruded through the conjunctiva. In her particular case, we could see very well this border of the plaque actually that was coming up, but I was not sure how much more it was extended posteriorly. And there were some hypotheses that the fact that sometimes it can extrude, it can be due to either sclerodehydration or sometimes because of the exposure to the sun, so actinic damage, or sometimes it's just mechanically induced by stress because of the sclera against the rectal muscles insertions. So beside this plaque, she had a lot of sclerothinning, so she had bluish discoloration away from that plaque, so she was looking down in the superior quadrant, and also nasally she had this thinning of the sclera. The cornea itself, beside the fact that she had folds and she had a shallow anterior chamber, there was some thinning present. In her particular case, although in some other patient it's present, some anterior uveitis can be diagnosed. And for this, for the majority of the patient with scleritis, the treatment is medical. And you can see that it can be started with drops, but sometimes we need systemic medication, either the oral NSAIDs or sometimes the big guns and the immunosuppressive in order to control the systemic disease that is the main culprit for the ocular findings in this case. Sometimes we do use protective lenses, but it's just a temporary measure and relief. It doesn't really do that much. And for this, for the majority of the patient with scleritis, the treatment is medical. And you can see that it can be started with drops, but sometimes we need systemic medication, either the oral NSAIDs or sometimes the big guns and the immunosuppressive in order to control the systemic disease that is the main culprit for the ocular findings in this case. Sometimes we do use protective lenses, but it's just a temporary measure and relief. It doesn't really do that much. So when medical treatment is failing, we need to do surgery in order to get the symptoms better, and as I will show you, to save the eye practically in this case. And it's not always easy. And the materials that could be used are diverse. It can be the amniotic membrane, and I'm going to talk more in detail about it, but sometimes fasciolata, it's used, periosteum, sometimes the dermis and split thickness, sometimes some synthetic material that companies have available. Aortic tissue was reported as well, or autologous or homologous sclera. This is a quick example of a patient that had scleral melting after undergoing cataract surgery, and 5 days later she presented with significant thinning at the limbus. And she did have practically complete resolution of the area of involvement about 2 weeks after having placed an amniotic membrane transplant. Also, I mentioned periosteum, and it's pretty common to be used by oculoplastic surgeons especially. What about the amniotic membrane, and what about our particular patients? So the issue and the problems with her, she was an older lady. She had significant disease with necrotizing scleritis and significant thinning. It did have this plaque that was coming out and wanted to come more and more, and part of it actually was a little bit mobile. Part of it was still held in place by the conjunctiva, but the part that was extruding at the border was with sharp margin because of the thickness and the calcium, and it was very irritating. She did have significant corneal decompensation, and she was leaking. The pressure was down to 3, and she had hypotony. So very careful, I did ultrasound biomicroscopy with her. We do have 2 units in the clinic, and we do have also a Visante. So in this particular patient, as you can see over here, you can see the sclera. I could visualize the whole thickness of the sclera, and this is the beauty of the UBM, because it allows you deeper penetration, and you can see the whole thickness and measure it. And look over here. I don't see almost anything because it's all this empty space practically and significant thinning. This hyperreflective area, it's actually the calcific plaque that I showed you clinically. When we did the other study, respectively the Visante, the anterior segment OCT, we can see a better view of the angle and the cornea. You can see that a little bit is missing over here from the information, but we already had it with the UBM. The same information practically was available, that plaque was overreading on the top, but there was not much over here. It was hyporeflective, and it was the significant thinning that was present. For the UBM, what is important is that the depth of penetration, as you can see over here, is much more significant. So actually you can measure the whole sclera in any type of scleral involvement process, and you can be sure that objectively you do have a number. And then after you do the surgery, you can see how it changed. In comparison with the Visante with the anterior segment OCT, the benefit of this technique is that the cornea and the angle is very well visualized, and there are beautiful photos with high resolution image of the cornea. But sometimes because of the limited depth of penetration, because it does not go through the pigmented iris epithelium, then we are not sure the pathology around it, if we got the whole story or not. So it can be missing some information. So after talking to the patient, I told her that I would not do the enucleation, but I will try to see what we can do for her, and that there are available all these sort of materials that we can try to use in order to put a patch practically. And if we cannot, then she would have the enucleation, but I would not go directly to that. So we took the patient to the operating room, and I had the surprise that the calcific plaque was much bigger than what was seen clinically. So practically it was just the tip of the iceberg. Not only that, but I had, as I was cutting and dissecting more and more and more, and my heart rate was going up and up and up, more higher. It was not ending practically. So I had to cut part of it, most of it, as I was removing it, because there was still something left and I couldn't bring everything out. So as you see over here, this portion, and you see here the bar to measure it, it's about 2/3 of the whole length of the plaque that was present. I didn't put the other part. what was done was that we did dissect the conjunctiva around that area and took out all the calcific plaque. As I mentioned, I had to dissect much more than I expected in order to remove it and cut it before taking it out. And there was a pretty significant defect for which we placed a tutoplast and we secured it with suture. On the top of the tutoplast, I use Amnio 5 because it's thicker, it's very easy to maneuver, and it listens to the surgeon practically. And I cover by using a much larger membrane to cover more, going beyond the borders of the tutoplast. And I secure it in place with Vicryl. You can use either 8O or 9O Vicryl in order to secure, and put it under the resected conjunctiva in order to have a smooth surface. You can place the Tysil glue, the fibrin glue, underneath the amniotic membrane after you place it in the location that you want. And then on the top of the cornea, remember that the cornea was not too happy. Plus she had rheumatoid arthritis and very severe eyes. I put an amnio disc. And then after I place it, I cover the cornea with a contour lens. And this was a big plus. The reason is because it had such a large diameter, 18 millimeters, it did not cover only the cornea itself and the area of involvement, but beyond that. So everything that we put before was secure in place, and her blinking was very easy and comfortable afterwards. To mention about Tysil glue, what I found in use with the amniotic membrane, we need to warm it up before you use it. So usually we keep it at room temperature about 15-20 minutes before use. Sometimes it's difficult to push the syringe that it comes with, and sometimes I like to use the two components separately, the thrombin and the fibrinogen, so you can separate that in two separate syringes. So that's how she did, and these are the studies that we did after the surgery. So I did not do the UBM, and the reason is that the UBM, it's not a good idea to do it in post-operatory patients because it's a contact technique. So although there is a saline, sterile saline interface that it's used like a contact media, you still put a transducer over there. So I wanted to wait a little bit longer. But with the Visante being a non-contact technique, you can visualize exactly. And we're happy to see that you remember that area that was hyporeflective. Over here it was much better looking, and actually the angle was deeper and it opened up. Comparing with what we noticed preoperatorily, she had, I didn't expect such a good result in terms of the vision afterwards. The comfort level, as I said before, she was thrilled, especially because she didn't have pain, but also because cosmetically she didn't need to have one eye removed. The pressure increased to 15. The deciment folds disappeared completely, and also the chamber became deeper. And at 5 months, I saw her about 2 weeks ago. She was stable and doing well. So which are the heroes in this particular case? I call them the savers. I don't have a video of the surgery itself, but you can see over here the very homogeneous white is practically the tutoplast. On top of it, it was the amniotic membrane 5, and you can see just the margin, so I used a larger size in order to cover. The amnio disc is not visible here, but it was placed on the cornea, and then it was the contour lens that was on the top of everything, and it was securing everything in place. I was very happy for her because I said no and let's try something different, and we ended up saving her vision, and that's when I got this little framed information from the National Geographic where she was, it was a pictorial about what she did. In conclusion, the amniotic membrane, it's a non-invasive, easy to use, very convenient, and most of all, beneficial tool that can be used in selected patients. The characteristic that making it such a success is that it does promote the healing, it cuts down on the inflammation, it can restore the corneal surface, and when you have selected cases, it can give more strength to the tissue. In this particular case and presentation, as you can see, the anterior segment OCT, it's a very easy to use, objective and reproducible diagnosis tool in order to monitor your treatment. Thank you.